right, my name is Jong, and Julian has already introduced me a little bit. As he told you, I'm working at the Erasmus University Medical Center right now. I did my PhD in Leiden, and I also have work as a researcher in a mental health care institution, which is called GGZ Noord-Holland Noord. And so I have two jobs, and I did a little bit of an irregular route for a PhD, whereas I did it in my own time while working full-time. And so this is a little bit different than most people did. So I'm not sure to what extent my PhD or dissertation is representative for other people's, but I'm just going to share my results with you, and yeah, let's do that. All right, so seems stuck again. All right, yes. So this is actually the cover of my dissertation, which is titled "A Chance for Change: Building an Outcome Monitoring Feedback System for Outpatient Mental Health." And I've based that cover on the quote from Sir Peter Rimmer and Bigman, who stated that without direct feedback on how their clients are progressing, clinicians are essentially wearing a blindfold while shooting at a target. So what's the content of my dissertation? It starts with a general introduction, then there is a section on methods, and what I did first was to validate the Dutch outcome questionnaire. This is the questionnaire that I used throughout my dissertation. You will know this as my Lambert's instrument. Then I did an article which is on power analysis in three-level multi-level models, which is a bit of a design paper for designing the three-level study that I'm going to talk about later, in which we added the therapist level as a level. And when I started designing this study, there was not, it wasn't available to do a power analysis for that. And so I wrote an article on this with Mirjam Moerbeek and Rien van der Leyden. Mirjam Moerbeek is at the Utrecht University, and she's an expert on this area. And so we developed a method to do this for these power analysis in these three-level, multi-level models. I will not be talking about those two studies today because I have three others that I will be focusing on. And that is the third one, which is a risk model for negative outcomes using CART and multi-level modeling, which is currently submitted. And two feedback studies. One is on outcome monitoring feedback in long and short-term therapies, which is also submitted, and one is on therapist characteristics as moderators for feedback effects. And then there is a general discussion, and I will also use some slides to discuss that. Okay, so risk models for negative outcomes. Negative outcomes are, there's a renewed interest in the area, and there have been a couple of special issues that were quite recently. And well, up until those issues, it wasn't something that was discussed very often, but it became a topic of interest, and what we see in those articles is that it is a complex concept to define. And it may include dropout or premature termination, non-response or no change, deterioration, and relapse or failure to maintain gains. And so also what we also see is the definition differs between treatment modalities. For instance, a psychodynamic treatment has a different definition of treatment failure than cognitive behavioral therapy may have. At least in those articles, it shows that psychodynamic therapists would consider it a treatment failure if the patient did not gain insight into themselves. And whereas for a CBT therapist, this might not be the case. What we do see is that common denominators for definitions of outcome throughout, overall these different treatment modalities are non-response and deterioration. So why do we want to predict negative outcomes? So negative outcomes are fairly common in clinical practice, much more so than they are in research, actually. And so between 3 and 14% of patients deteriorate, and 45 to 60% show no reliable change. So negative outcomes is a huge problem, actually, in clinical practice. And so prediction models may help us identify patients who are at risk for negative outcomes at an early stage in therapy. So what did I do? I collected outcome monitoring data from outpatients in 3 mental health care institutions in the Netherlands, and that resulted in a data set, final data set of 1,540 patients. And I started this study in 2006, which was when there was not much routinely outcome monitoring. So I actually sort of set up the outcome monitoring for this study myself, and so it was a lot of work to collect this data. The patients were 60% female. You can see that the main diagnoses were mood and anxiety disorders, and the OQ45 was administered at session 1 to 5 and then every 5th consecutive session. And the predictors that we included were, we chose predictors that are often commonly measured at intake or might be measured early on in therapy. So that included clinical characteristics, demographic characteristics, the early working alliance, and expectations of outcome. We defined negative outcomes as patients who deteriorated or showed no change on the OQ45, but they had to be in the dysfunctional range, which is a score higher than 55 for the Dutch OQ. That is 63 for the American OQ at the end of treatment. So according to this definition, 49% of the patients had negative outcomes, 130 deteriorated, and 579 showed no reliable change. So the analysis, what we did was we approached this in 2 ways. When you think of outcome, there are several ways to sort of assess that, and we decided to do an assessment both of the end state functioning and the rate of change. And so this is how we approached this paper, and so we chose to do a classification and regression tree CART, which is, I'm going to explain a little bit more about later, and that's going to predict end state functioning, and a multi-level model to predict the rate of change. And we used multiple imputation for the missing data on the predictor variables. So the classification and regression trees are almost literally a tree. As you can see here, I have a little picture there, is that the CART algorithm searches for split points to create more homogenic subgroups. And what happens is that that process goes on until sort of every subgroup has homogenic outcomes. And so what you get is that it will go on until, for instance, there's only one patient in every endpoint. And so what you get is an overfitted tree. And because an overfitted tree is not likely to be replicated, and the predictors that are sort of lower in the tree are also the less important ones, the tree is pruned back based on a cost complexity analysis until an optimal tree size is reached. So After pruning, we selected two card models. One was the optimal tree size, which had 3 nodes, and one was the extended model, and that was sort of the next step that had a comparable cost complexity, and that was a little bit more extended. So I'll show you the 3-node model. So we started out with the full sample. You can see that we had to drop some cases here. But then, so the first predictor was the initial score on the symptom distress subscale of the OQ45. And it was split that the card model automatically found that people with a score on the SD subscale below 27 had more favorable outcomes, and so they were considered a subgroup. And then people with a higher score of 27 or higher, they went through in the model. And for those people, then education was the best predictor. And as you can see, people with a higher education had more favorable outcomes, and then sort of had here, bigger chances of positive outcomes. And people with a low or medium education, which is the largest group, as you can see, they continued in the model. And then we have sort of the final node for this 3-node model, and that is that people with low expectancies on their outcome had more negative chances of higher increased chances of negative outcomes. So they were considered another more homogenic subgroup, whereas the rest of the people ended up in the other end of the tree. So if we extend the 3-node model to the 9-node model, then we get this. So the 3 nodes that are above this are still there, but I'm going to continue. Those trees are nested within each other. If you remember that it's like one large tree and it's pruned back, then you can understand that, this is sort of an extension of the 3-node model. And so what we see here is that initial social role, which is another subscale of the OQ45, was the next best predictor, and you see that people with a bit more higher scores in social role had better outcomes. And then we see here that the GAF score, the XS5, the Y task scale, initial severity on the SD subscale, initial severity on the interpersonal relationship subscales are all predictors of subgroups of outcomes. And you can see that all the outcomes that are on the left side are sort of the squarey ones, so the square ones with rounded corners, I should say, which are light gray, are the ones that have more favorable outcomes, whereas the dark gray square ones, or rectangle ones I should probably say, the darker gray ones have less favorable outcomes. Okay, so then we predicted the rate of change. And what we found was that the 3 subscales of the OQ45 were all predictive of the rate of change, as well as the GAF score and the Working Alliance Inventory Goal subscale. So here you can see a rate of change. What we wanted to do is we wanted to compare the model performance of both models. But since rate of change does not necessarily say something about the actual outcome, because it's rate of change, we wanted to say, okay, how can we define based on the rate of change whether this patient is at risk for negative outcomes? So what we did is you can see a dotted line here, which is the expected treatment progress of this patient, and then you can see a light gray and a darker gray line, and those 2 lines are reliability intervals. And So if the patient, and you can see the actual scores of this patient in the black line with the dots and the actual scores there, and if a patient exceeds the confidence interval, the two failure boundaries, then we consider this patient to be at risk for negative outcomes, and this is in line with how this is defined within the feedback studies of Michael Lambert and also the work of Wolfgang Lutz. Okay, so this is how we defined the at risk based on the rate of change model. So if we look at model performance, we are seeing here the sensitivity and the specificity of both the CART models and the deterioration, and the multi-level models with the 68% failure boundary and the 75% failure boundary. Remember, those were the light gray and dark gray lines in the previous picture. So what we see here is that the CART model, especially the 3-node CART model, has a high sensitivity, whereas the 9-node CART model has somewhat lower but still okay sensitivity, but much better specificity. So the balance is much better in the second model. What you can also see is that the multi-level model is not very sensitive, but it's very specific. So those two models really complement each other in terms of how they perform. What we also looked at is deterioration, and for this multi-level model, and those two models show that the multi-level model is really sensitive to predict. It's sensitive and specific for deterioration, but not for negative outcomes in general. Okay. So, what are the conclusions of this study? And I see that we have a question, so I'm going to stop after this for a little break for questions. The predictors for negative outcomes are similar but not identical for end-state functioning. This was one of the things that we saw. The multi-level model was not very good at predicting negative outcomes, but was very good at predicting deterioration. And the extended CART model had the best trade-off for predicting negative outcomes. What we also if we use both models together and we look at the clinical implications, like I said, two models, they complement each other in terms of sensitivity and specificity. So what you get is 4 sort of types of patients, basically. You have the patients that have, they have a predicted positive end state, but they have negative change predicted. So, this may be patients who have mild symptoms and are already in the normal range. And then we have patients who have a predicted negative end state and also a predicted negative rate of change. Should we consider more intensive treatment with these patients? These are like predictions for new patients. So if you get a new patient and you already know at the start of therapy, or at least the beginning of therapy after 3 sessions, that they have a negative predicted end state and a negative rate of change. These are probably the patients who are most at risk for negative outcomes. Then we have the patients who have positive predicted end state and positive predicted change. These are most likely, your success cases, and what you could consider here with those patients, like if you are using feedback systems, you know that Michael Lambert uses feedback like every session. That's very intensive. Also for the patient, they have to fill out a lot of questionnaires. You may want to consider, relaxing monitoring for these patients a little bit, considering that they are having good chances to have positive outcomes. And so then we have those patients who are expected to have positive change, but have a negative prediction for the end state functioning, you might want to monitor them intensively during therapy in order to be able to see how they end up in the end. Okay, so let me just have a short break for questions.
Yeah, there is a question by Andy Fugard, or Andy Fugard, I don't know how to pronounce it, and he asks, just wondering how those intervals were computed exactly based on reliable change criteria. And he also asks how Mike Lambert does that not on track stuff. So he asked for the exact calculation of these.
Well, the exact calculation, I'm not sure that I have that here. It's actually a calculation that was given to me by Wolfgang. It's based on the variance in the multi-level model. So it's an confidence interval for the multi-level model. And so it's sort of like a normal confidence interval where you also use the variance, but obviously the variance in a multi-level model is a little bit different. And so there's a formula there. If you want to have it, you can email me and I'll send it to you. And actually, Wolfgang also did the calculations for Mike's model, and so it's a similar approach to that. Does that answer your question?
Okay, yeah, it does. Thanks for the answer.
Okay, great. Any other questions so far?
No, not that far.
Okay. All right.
Oh,
so
sorry. There's another question. Maybe Jim Payne asked, did you consider using a less intensive outcome measure such as the outcome rating scale, session rating scale, which is less intensive than the OQ45, so the instruments from Duncan and Miller?
Yes. Yeah, I did consider that, and I chose not to. Why is that? Well, one of the reasons is that the sensitivity to change for an outcome measure is related to its length, and so the ORS is really a 4-item measure, which has the disadvantage that it's less sensitive to change than a measure such as the OQ45. And actually we see this. I'm collaborating with Pauline Janssen, who is a Dutch researcher, and she's doing a study right now with the ORS, and this is actually what she found also, that it's less sensitive to change. And so she also has the SL90 in her study, so that is showing the change. But that's actually the reason that we didn't use that.
Okay. Does that answer? Okay.
I hope so.
Yeah.
We have a raised hand, I think.
Oh, okay. So, yeah, George Barbosa raised his hand, so I unmute you now, George.
No, thank you.
Okay, so you can speak. Oh. Not sure.
I heard him say thank you.
Yeah, he is unmuted.
George, are you there?
Okay, so maybe he changed his mind.
All right. And is there another? I see still raised hands.
No, no, that's all.
That's all? All right.
Yeah.
Okay, I will continue then. Right. So, routine outcome monitoring and feedback. This is the second part about the feedback studies that I, announced in the beginning. So again, very shortly, explanation that in clinical practice, results of therapy are less optimistic than they are in research studies, and a lot of patients do not have positive outcomes. In part, this is caused by a selection bias in RCTs, where sometimes not the very complex patients are included, which will result in more positive outcomes, but this does not account for the full effect. And it seems that there is still some opportunity for change. a chance for change. Now you know why that was the title of my dissertation. And so monitoring patient progress and giving feedback to therapists on this might be a promising way to improve outcomes. And also, we need more efficient care. This is a feature from the Dutch expats newspaper, and you know, the costs of healthcare are extremely high, and I'm sure this is the same in other countries in the world. And also, because of the current economic crisis, there are huge cuts also in the budgets, which means that we can help less people or have to be more efficient. So it's very urgent that we become more efficient in our therapies. So what's the evidence on feedback? Probably most of you have seen Mike Lambert's talk, which was earlier this year. But if you have not, you can see that I'll tell you a little bit about it. So the evidence is that really the efficacy of feedback is mixed. The studies by Lambert show really large effects of feedback, but then there's also a couple of reviews that show smaller effects. And another thing that we see is that the effects are highest on the not on track cases, but there is no effect for on track cases. So what are the effective elements of feedback? So as I said just now, that the largest effects are found by Lambert, and he has a high frequency of measurement, and he uses expected recovery curves, similar to what I just showed you as recovery curves with warning signals, and he also uses clinical support tools on common factors, but most of the feedback systems do not have these elements. All right. So let me tell you a little bit more about feedback theory and how feedback works. And this is based on this contextualized feedback intervention theory by Len Bickman and colleagues, but I've adapted it a little bit to fit my own studies. Okay, so what is feedback? When you get feedback, basically you are comparing the information that you're getting to a goal or standard. And in the case of a therapy, usually the goal or standard is that, well, the standard could be, you know, what is the normal change for a similar patient, or sort of the predicted cause, the predicted course of therapy, and the goal could be to, you know, decrease symptom distress for this patient. And so when you get feedback, you make a comparison as to whether you are on course with this therapy and whether, you know, the information that you're getting is concordant or discordant with your goal or standard. And so if you get a discordant feedback signal, then this will lead to cognitive dissonance, which in turn will motivate you to change your behavior. However, you know, this is the ideal situation. Not every case this will be how it goes. So one of the things that can happen is that, you know, what if you're not so committed to the goal? Fortunately, most clinicians are quite committed to the goal of helping their patients. But, you know, for this specific patient, you might feel that you're not, you have trouble sort of reaching something with that patient and being able to get this patient to better outcomes, and that may actually reduce your commitment to that goal for this patient. Also, let me just go here. The feedback does only work if you sort of have attention for it. And there are a couple of factors that are related to the effectiveness also of the feedback. One of the things is the valence. So if you get positive or negative feedback, the content, what kind of information are you getting, and also the timing. If you get it faster, usually it's better. It has more effect. The content here is like the type of information you're getting. For instance, if you also get information on the process, you may be able to sort of have more ideas of how to change things with this patient rather than when you just get the signal that the patient's not progressing. And the valence, we know that people are more likely to accept positive feedback. But we also know that with this feedback system, negative feedback is the most effective, or at least sort of the feedback has the largest effect for those not on track cases. So when cognitive dissonance is there, it doesn't mean that the therapist is going to change their behavior necessarily. So what we also have is that the therapist has a preference for feedback, which we call the feedback propensity. And you can have an external or internal feedback propensity. If you have an external feedback propensity, then you usually already seek feedback from other people, actively search for it, ask a colleague when you are in doubt of something. And there's also people who are more likely to rely on their own opinion. And so, regardless of what kind of information they're getting from others. So people differ on this trait. And so do therapists. So, this might be an important factor in, whether people will be open to this feedback and be likely to change their behavior. Another factor that is important is self-efficacy. And this is sort of the role-specific self-efficacy for, being, how confident are you that you can help this patient. And what we know from the literature is that people with higher self-efficacy are usually better able to deal with negative feedback. And so, they're usually it makes sense. It is not necessarily related then. If you get negative feedback, you do not automatically think I'm a bad therapist, but you're sort of more able to look at what you can change without it affecting your ego too much. All right, so then we have the perceived validity, which is do you perceive the feedback that you get as valid? So for instance, if the therapist thinks that the OQ45 is really a questionnaire that is rubbish, then how likely is the therapist to actually do something with the feedback based on the OQ45? So this is all relevant for, how does this feedback work? So I have a question for you that seems sort of unrelated to what I'm talking about now, but it is related to what I'm going to talk about in a bit. So you'll get a poll right now. See that the poll is in progress, and 42. I think you may not be the best audience to ask this question to. You seem to be quite moderate in your answers. All right, so it seems, let's see, 63% has voted. So if you haven't voted yet, to vote now. All right, so it seems to be changing like all the time. Okay, 74% of you have voted right now. All right, so should we close the poll? Let's do that. And share. Do you have to, if all's well, you can now see it on your screen. So half of you have answered to some extent, and half of you have answered to a medium extent. So you guys are quite moderate in your expectations of how well you can predict outcomes for your patients, which is good because you know, how well can we actually predict treatment failure? Oh, let's go back up. Okay, let's go back. So there was a study that was done by Hannon, which was a grad student of Lambert, and what they did was they asked therapists to rate their full caseload and predict which clients were at risk for negative outcomes. And they've been working with feedback system for quite a while, and they knew that the rate of deterioration was usually 5 to 10%. So everybody was asked to rate their full caseload, and so 3 patients were predicted to have negative outcomes by the therapist, whereas 40 patients had actual negative outcomes. So the therapists really underestimated the amount of patients that would have negative outcomes, and they were accurate in predicting the right patient only once. And so when they compared this to algorithms such as the prediction model that I just showed you for feedback, that those models were correct in predicting negative outcomes in 77% of the time. So there was a huge difference between that statistical model and how well therapists predicted negative outcomes. So we did a replication a little bit differently, but within a clinical trial on the effects of feedback, in which we have 2 feedback conditions. One is sort of feedback without prediction model, and one is feedback with prediction model, which we call complex feedback here. Were they able to predict, and did it depend on the feedback condition that they were in as to how well they were predicting? Now, as you can see here, again, therapists are, really underestimating the amount, or this is the actual the other way around. So this is expected recovery as opposed to expected deterioration. And so you see that they expected most of their patients to recover, despite their knowing that half of the patients were likely not to recover. And so the actual recovery rates were much lower than was expected by the therapists. And it did not matter, actually, in what condition they were. So getting the feedback did not really alter their expectations, which I find fairly interesting, to be honest. How does this work in the mind of the therapist? That's something I really want to do more research on in the future. All right, so the feedback studies. So what we wanted to do was develop an outcome monitoring system for outpatient mental health care in the Netherlands. And we had a couple of research questions, and that was, does the outcome monitoring feedback improve outcomes? Does it affect treatment duration? And do therapist characteristics moderate the effectiveness of feedback? So I did 2 studies. The first study, we had 3 groups: a control group, a therapist group, and therapist and patient feedback. The feedback consisted of a progress chart, feedback text, and risk items. And the OK45 was administered prior to every session. And we had private practices and outpatient mental health care institutions included here. And the therapists were participating on a voluntary basis. And then the second study, we had two groups, a control group and a feedback to the therapist group. And the feedback consisted of two progress charts, two tables with the numbers there on the scores, the risk items of the OQ45, and here the OQ45 was administered prior to session 1 to 5, 10, 15, every consecutive fifth session again. Which was all outpatient mental health care, and here we had 3 departments, and they were just sort of, the department participated. So all of the therapists there, had to be in the trial. All right, so let me tell you about the first study, patient and therapist feedback. Here are the results. And let me just go through this graph with you. As you can see here on the y-axis is Cohen's d, so this is the effect size for the therapy. For the on-track patients, there is a positive effect that is, there's a positive effect for the therapy over time. This was analyzed with a multi-level model, by the way. If we look at the not on track cases, we see that if we look at the not on track no feedback group, which is not NFB, which is the lowest line in the graph, there is a negative effect of, there's a negative effect size over time, so these patients are deteriorating. If we give feedback to the therapist, which is the not FBT group, so there's feedback to the therapist alone, the negative effect, the deterioration is much lower on average. So you can see that the rate of change is smaller, so there's no longer, there is a much smaller negative effect, a much smaller deterioration for these patients on average. And then if we look at the not on track feedback to patients and therapists, then we see that sort of the deteriorating effect is resolved. So on average, this group is no longer deteriorating, despite the fact that they were not on track. So they deteriorated in the beginning, and then after that, they apparently had positive change again, up to the point that on average, from the beginning, they didn't experience negative change. So this is the result in short-term therapies. And this was defined as therapies up until 35 weeks. Now, if we look at long-term therapies, we have a really different graph. So again, Cohen's d is on the y-axis, and what we see here is that there's no longer a difference between on-track and not on-track patients for the effective feedback. What we also see is that the no feedback and the feedback to therapist group are no longer different, so they do not differ in their effect. What we do see is that feedback to therapists and patients together in those longer therapies, which were between 35 weeks and 2 years, is bigger. So here the positive, the feedback has to patients and therapists has a positive effect, regardless of your being on track or not on track. Okay, let me stop very briefly for questions here.
There are no questions. There's just a supportive comment on your poll by Jim Payne. He says, the research is clear in this regard. We do not predict how our clients are rating even a sessional measure of the therapeutic working alliance.
Okay, all right. Yeah. Well, thank you, Jim, for sharing that. If there are no other questions right now, let me just wait for a few seconds and give people the chance to raise their hands or to type in a question. Then I will continue.
Maybe I have a question.
All right.
What do you conclude from this research on short-term and long-term therapy? So is feedback more important in long-term therapy, or what do you conclude?
It is difficult because we don't really know for sure, but I think that, and we talked about this with the therapist as well, I think in long-term therapies, you have more time to discuss, to sort of identify not on track patients yourself. And what we should also consider, I think, is that those two groups are different in a sense that the therapists up until 35 weeks also included people who may have dropped out prematurely, whereas the group of more than 35 weeks in therapy at least consists of patients that are willing to stay into therapy for at least 35 weeks. So I think that's a difference as well.
Mm-hmm.
Yeah, so that's what I think, and also the fact that the therapy to patients and therapists together is more positive in both short and long-term therapies is, I think it's caused, and that's also what we heard from a therapist, that by the fact that the patients, when they get their own feedback, is more sort of empowered by it, because they can actually discuss with their therapist based on their feedback graphs. I am not happy with this amount of change. I want I want bigger improvements, or what's happening here. So they're sort of emancipated in a way. They can address this with their therapist based on the graphs themselves. So yeah, they can use it as a communication tool. So this is my thought on why this effect for patients and therapists is bigger.
Okay,
I
thanks.
see that.
Yeah, there's another question
Yes.
by Andy Fugard, and he asks if there's any possibility that clinicians can capitalize on chance when getting feedback. So scores wibble around a bit. Clinicians then discharge when they wibble by chance in the right direction.
Yeah, so this is always, obviously this is always a risk. Scores always wibble around a little bit, because you have error and things happening to the patient, etc. And yeah, I think you're right. If therapists were to actually do that and discharge patients based on the feedback, my experience though is that they don't do that. They're sort of basing it on their own judgment, and in conversation with the patient. And so I don't think this is really sort of a big problem in practice the way it's used. But you're right that they might be able to sort of, when it's when it's getting better and a patient may have an accidental positive score, if they end therapy, then they may have better results on average. I think in practice most therapists don't do it like that.
Okay, thank you, Kim. There is another question by Tommy Skulsick, and he asks, how was the feedback delivered to the patient? By the therapist, I suppose. How do therapists feel about giving this feedback openly to the patient?
Now, actually, the therapist didn't give the feedback. The patient actually had access to the feedback directly after completing the questionnaire in the questionnaire portal. So they had direct access to their own feedback.
Okay, does that answer your question, Tommy? Okay, thank you, Kim.
All right, I'll continue. So the second study was on feedback to therapists, and remember that I told you that this time we were also interested in what the therapist would do with the feedback. Okay, let's see if I can get to the next slide. So this was the effect of the feedback for the whole group. And as you can see, there is no effect of the feedback if we look at this graph. So there was a little bit of a difference at the start for the not-on-track cases, but overall, at the end, there was no effect of the feedback. Well, you can understand that we were a little bit disappointed when we got this. But remember that I said that, the previous study, the therapists volunteered to participate. Whereas in this study, the therapists were forced to participate because their manager had decided that they would participate in this study. So these 3 departments, as you can imagine, not all of the therapists were equally motivated to actually use the feedback. So what we did is we asked them, how did you use the feedback in those clients? And they could, fill out lots of things. And, what we then coded was active use of the feedback. And what we saw was that when the feedback was used in an active way, there was an effect of the feedback for the non-on-track cases. As you can see here, it's not a very large effect, but it's significant. And so for the active, the active users of feedback, the feedback was helping them get better results for their not-on-track cases. So then we wanted to know what kind of characteristics for the therapist actually may sort of moderate the effects of treatment, of feedback. And so we looked at characteristics of the therapist. In the feedback theory that I discussed before, those factors were included. And so we looked at, how did the therapist perceive the feedback? What was their feedback propensity? What was their attitude towards the routine outcome monitoring, and so on. And so what we found was that therapists with higher internal feedback propensity achieved change slower, and this was regardless of whether they got feedback or not. And the same was true that having a positive attitude towards the routine outcome monitoring, and that's the feedback, this resulted in a faster rate of change. So basically, it seems, again, regardless of getting the feedback, it seems that the positive attitude towards getting feedback from external sources is actually predictive of the rate of change in therapy in general, regardless of whether you get feedback or not. So it seems like sort of a basic attitude of being open to feedback from others that makes you a more effective therapist, regardless of whether you get feedback or not. What we also found, and this was already, like I said, found in the literature, was that therapists with a higher self-efficacy achieve faster change in non-on-track cases. So what I said before, this makes sense. If you have a high self-efficacy and you feel confident in your role as a therapist, it is understandable that negative feedback does not threaten your self-esteem. And then, so here we actually find that they have better results compared to therapists with lower self-efficacy in those not-on-track cases. So then we also looked at, the use of feedback. Could we predict that? And what we found is that people who had a more positive attitude towards the feedback at the beginning of the study, we measured this at the start of the study, were also, this was related, and this is not very surprising, but, still, to a higher active use of the feedback. And then another interesting finding was that women were 4 times more likely to use the feedback than men were. And so, yeah, I talked about this result with Jeremy. God, I forgot his last name. This is embarrassing. So I talked about this with a colleague, and he said, this makes sense because who's asking for directions when they're lost? So I thought it was an interesting comment on that result. All right, so higher self-efficacy correlated with a more positive attitude towards ROM, routine outcome monitoring. This is another study. And what we also found was that higher external feedback propensity correlated with a more positive attitude. So this makes sense in the context of the feedback theory. We also looked at the personality of the therapist, and we found that therapists who were higher on extroversion had a more positive attitude, and therapists who were higher on neuroticisms had a more negative attitude. Okay, so we also studied the effect of feedback on the treatment duration. And what we found was that there was a trend for shorter therapies in the on-track cases, but it was not significant. And in the not on-track cases, there was no effect of the feedback on treatment duration. So the conclusion that we can draw from these feedback studies is that feedback can help improve treatment outcomes, but it's a complex process and it does not work equally well under all circumstances. It seems that feedback to therapists and patients is more effective. We found larger effects in short-term therapies than in long-term therapies, and feedback seems especially effective in not-on-track cases. And then we also found that therapist characteristics moderate the effects of feedback. Okay, so let me just go to my final slides and then we can have some explanatory questions. So I have some methodological considerations. What we did in this study, or in these studies I should say, is we used the OQ45, which is a measure of symptom distress, interpersonal relations, and social role. But the largest part of the instrument is on symptom reduction. Whereas sort of that's, the focus there is sort of based on symptoms, which is not the same as mental health. So you could wonder, you know, are we achieving mental health with these patients, or is it just symptom reduction, and do we not measure some other aspects that may be important in therapy? We also used a self-report instrument, and this may result in different outcomes compared to when you use other perspectives. For instance, when you use like a spouse's perspective, or an employer's perspective, or a parent's perspective, you know, people in the surroundings of the patient may think that the results are different than the patient themselves. Another thing is that the definition of treatment success and failure is complex, and so we picked one, but obviously in this definition there is a group who is progressing but is not progressing enough to be a reliable change, to reach reliable change, but they are progressing. So maybe this group is a little bit different than the group that is deteriorating. And so it is complex to find a really good definition of treatment success and failure. We chose this one. It's a common one, but you know, it may not be the best there is. And then there's the matter of cultural equivalence. Most of the research that is done in this area has been done in the United States, and so you know, it may be that we find different patterns of change or different sort of responses to the questionnaire, etc., in our Dutch sample, which I think, you know, could be interesting. One of the things we know, and that's from the first study that I didn't discuss today on the OQ45, the Dutch OQ45, is that Dutch people tend to score lower on the OQ45 compared to Americans, so less severely distressed. So this seems to be like a cultural thing rather than, you know, the American patients being more severe. So what are the implications for clinical practice? I think we need to think about who are we providing the feedback to? Should we just do this to the therapist or also to the patient? Actually, in a study that we are now working on, we've provided feedback to the patient in severe borderline patients, and what we found there was that the feedback had a negative effect. And I know that a study by Flip van Oene, also in the Netherlands, with the ORS, demonstrated they used feedback in crisis patients, and those patients also deteriorated when they received feedback. So we should really, study more which patients, benefit from getting the feedback compared to those who might actually get worse with getting feedback. Other the characteristics of the feedback are important. How often do we measure the functioning of the patients? Mike Lambert does that every session, as well as Scott Miller does. But then, that gives you the best opportunities to sort of detect a patient that is not going well, but then you have a large burden for the patient. Now, using prediction models is something that could be interesting to implement into clinical practice. Tailor the feedback to therapist characteristics is something that I think is a future course that we should go on. And measuring process variables as well as outcomes may also be interesting. So future research, the ideas that I have on that is both on methodological innovations. We should look at nonlinear relationships between predictors and outcome, more dynamic individual patterns. There are, wonderful techniques right now that are sort of evolving and, should become available to do that sort of thing. And, in terms of feedback studies, we should study new patient groups outside university settings, which, in fact, we did use settings outside of the university. But a lot of the studies are done in a university setting. Optimizing the feedback, use of advanced prediction models, and also very importantly, we have this contextualized feedback theory, but it still remains untested for the largest part. We did this study, I think Bigman did a couple of studies, but it's not a lot of work done in that area yet. So that's it.
Yeah, thank you very much, Kim. We have a couple of questions and one raised hand by Jeremy Halstead. He put it already down. Maybe he just wanted to sign that he was the Jeremy you talked about, the women.
I'm sorry, I forgot your last name. I'm sorry, Jeremy.
I think he won't mind. Okay, so Len Mickman asks, do you have any data on what percentage of therapists and clients actually viewed the feedback?
Yeah, that was 50%.
50% of the therapists and 50% of the clients?
No, for the study of the therapist and the patient, we didn't have that information. But for the second study with the active use, that was we had sort of the therapist received an email, and I received a notification when they opened that email. So, I mean, there's no guarantee that they actually use it, but at least it gives you an indication of whether they open the email with the feedback.
Okay.
And they usually did.
Mm-hmm. Okay.
But I don't have any exact numbers.
Right. Good. There's another question by Jim Payne, and he asks, how would you integrate the different feedback with the feedback with a different perspective, so therapist perspectives and client perspective, I think is meant. Mm-hmm. Yeah.
Well, that's an interesting question. I think it's complicated, but it's also interesting. Well, I also do a study with child or youth youth setting, and what you have there is always the perspective of at least with adolescents, you have the perspective of the child and you have the perspective of the parent, and those two are different. And so what you do then is sort of you sort of open that perspective to in the conversation about the results with the patient, and in this case the patient and their parents, sort of like, okay, do we recognize that you have a different angle on this? Could you, you use it to sort of open up the conversation about that. I see that Jim says here that he also means other parties such as a spouse or a parent. I'm not sure if you should always ask the partner, to continually say something about how the patient is progressing, but it would be interesting, I think, to do this occasionally and see sort of, use that and maybe sort of discuss it with the patient, or maybe even with the partner or spouse present there. Well, I guess it's a matter of sort of figuring it out, because it hasn't been done that much, I think. Except in couples therapy, I think there you always have those two perspectives. I don't know if this is a good answer to your question.
He said the reason I said partners, but he said yes, it's a good answer. Right. So did a good job. Good. Thank you, Kim. There's another question by William Andrews. He asks, how were the therapists trained in the use of feedback?
Yeah, what we did is we gave them a training at the start of the study, and then we sort of taught them how the feedback was used, and how they could interpret the feedback. So we gave them a chart, a sort of a plastified chart which had, sort of those bullets and, enlarged, and sort of they had that on their desk, so they could use that to help them understand what the feedback would mean. But it's a very good question, because it's something that is an issue in implementing these systems, is that you often don't get access to the therapist more than once. When you start a study, everybody's still very motivated, and they think, okay, you should give them a training, and that's basically one of your few chances to interact directly with those therapists and train them. And very often you don't get much opportunity after that. So at least in my experience, then there's other stuff on the agenda of the manager, and they don't want to give you their management time they have with their team to discuss the study. So yeah, that's a complication actually in the implementation of these kind of studies. Is that enough answer to your question, William?
Sort of.
Okay.
Okay.
Right. I hope that's
we have
good
to
enough.
go on. Yeah, so I think our last question before we hand over to Wolfgang is by Jeremy Halstead now, and he asks, what are your thoughts on alliance measures? We used the ARM5 and found seeding effects, so no discrimination.
Yeah, this is interesting, because I've been, as I told you before, I've been working on a study also with Pauline Janssen, who is working the ORS and SRS, which is the Scott Miller and Duncan system. And what we found there also is that the SRS wasn't very it was sort of fluctuating a little bit, but there wasn't a real pattern of improvement or change. So it seems that although the alliance is important sort of as a process measure, it's not very much related, at every point to be connected to outcome. Another thing is that I noticed ceiling effect of those alliance measures, and we now use the clinical support tools for Mike Lambert, and that has an alliance scale in there. And what we do is we have the cutoffs really high. So if you say Do you think your therapist is happy to see you? And you have a score from 1 to 5, and 5 is most positive. If you score a 4, it's considered a problem. So, I think one of the ways is to sort of, make the threshold for a problematic score really low. I hope that's an answer to your question, Jeremy.
We also found the Lambert ASC scales helpful from that point of view, says Jeremy.
Yeah, the ASC scales are the clinical support tools that Lambert uses.
Yeah.
That's the questionnaire that's used, yes.
Yeah. Okay, so I think we should hand over to Wolfgang.
Yes.
We'll very briefly introduce him, because you all may know him. Wolfgang Lutz is currently full professor and chair of clinical psychology and psychotherapy at the University of Trier in Germany, as well as the director of the clinical training program at the outpatient research clinic at the University of Trier. And he has published widely and over 80 peer-reviewed papers, and is one of the pioneers of patient-focused and feedback research. And he worked in this area in several countries using service research data from the US, the UK, Switzerland, and Germany. He also is associate editor of the journal Psychotherapy Research and of the German Journal of Clinical Psychology and Psychotherapy. So, yeah, we're very happy to have him to discuss this first dissertation dissemination webinar. So, Wolfgang, please.
Hello. Thank you very much. Thank you very much, Julian, and thank you very much, Kim, for having me. I was on your dissertation committee, and I think it's very clear that this is a very, very nice dissertation, and you really have earned your festivity in Holland, because a dissertation in Holland, and after it, there's a huge festivity with the whole family. It's almost like marriage, and this is really, it's a real something, a real experience, really wonderful. So now back to the work. I mean, it was a tremendous amount of work, and especially because feedback research usually is it's not an easy task to do, especially doing a large study as part of a dissertation, or in your case, several studies as part of a dissertation within those service settings, to having therapists participating. It's usually a very challenging research environment, and I think it really can be said that you already established yourself as having a very international reputation, and being one of the leading figures on feedback research in Holland. So with this dissertation, and I mean the results are to see it's mostly in line. We can discuss this maybe later with the international developments in this area. So we have now studies in the US, mostly in the US by Michael Lambert, Len Bickman. We have them in Germany, in Holland, Australia, and in the UK. So now we have like an international group of people doing feedback research, and I think this is still an exciting new area of doing research. And you asked me to put this in a broader context, and the clinical implications and future research questions. So I would see feedback research as part of patient-focused research, which is again part of practice-oriented research within our field. And in my opinion, that's the main supplementary paradigm of research to evidence-based practice or guidelines and manuals. So I think that's really a very big part of psychotherapy, or new part of psychotherapy research, as well as scientist practitioner networks, and can be maybe even seen as part of scientist practitioner networks. I would like to highlight a few issues which might be interesting in terms of future research questions, and which also came up in my mind when I heard your presentation. I think treatment length and to study this as the effects of feedback depending on the treatment length. So we have very different treatment length in different countries. So this is very interesting issue itself, and might be even feedback can be used as part of stepped care approaches. So which gives some guidelines to say if people need longer or shorter term treatments. I think there are a few plans with this in the UK, but it will be an issue if that's possible at all or not. And connected to this is the development of decision support tools or decision rules, which help us to do these kind of decisions. And can we do this? And are therapists willing to participate in those kind of studies? Also, which comes to this finding of yours that the effect of feedback depends also on the therapist. I mean, how open or the openness of the therapist to feedback. And this brings me actually to an issue which I really try to develop here in our clinic, is that feedback is already part of clinical training. It really has to be part of clinical training, and that's one of the main clinical implications from my point of view, is that it has to be part of clinical training and of therapy. So it's all like blood pressure measure or whatever you do in a primary care practice of a medical doctor. So that's an important issue, that this should be part of clinical training and part of therapy itself. So it is part of therapy. It's not something additional. So in most of our studies, it's almost seen as a part of something additional, but I would even see it as part of the clinical work. The other issue, which might also in terms of future research possibilities, I think there's now a huge debate about e-mental health. So using some mental health supportive tools, intervention tools. We call this usually as internet therapy, but you could also think that treatments or psychotherapy can use additional tools like which are placed on the internet, so they can be part of the feedback tools. The therapist maybe can make use of those when they provide homework or whatsoever. So this could be also an interesting new development within feedback research if we add on our feedback and add possibilities, intervention possibilities, basically like Mike started it with the clinical support tools. So I think I will also end here and we open the debate again to all the participants. And I think also, which is maybe at the end, which we might want to discuss, how can we get therapists to be more open to feedback, to be part of this kind of studies, but also to use it within their environment. I think that's a very important issue. Yeah, let me stop here so we can maybe more openly discuss this.
Muted, unmuted.
Okay, thank you, Wolfgang. There's a comment by William Andrews who said, I absolutely agree with this point and think it is key. And I think he meant that feedback should be an integral part of clinical training already, so that therapists learn how to use feedback to optimize treatment. Okay, are there any other questions? Or Kim, would you like to comment on what Wolfgang said?
Well, I think he's absolutely right that feedback should be used in clinical training, and you know, people being used to sort of being trained. And I think it's also a great tool in training where you have to sort of use it in supervision and you know, as a way of sort of becoming more confident as a therapist. Or it's very important that you get feedback on how you are doing, and I think especially in clinical training, you know, in sort of becoming a therapist, it's very useful to get this kind of feedback on how you are doing with patients. So I think that makes it especially interesting in that sort of setting.
Right, right. William also says building use of feedback into supervision is a great way to help integration of feedback into therapy. And that is what you said, Kim.
Yeah, I said it specifically in the context of clinical training, but this can be extended obviously to supervision, but also what we call, I don't think it's a term in other countries, but we call it intervision if you're no longer in training and you're sort of using the advice of colleagues and other therapists. You can actually sort of bring your feedback charts to the...
Am I still online? Can I still?
Yes, yes.
Oh, okay. In our country, in Germany, there's usually this debate about using those for clinical decisions. Or basically, when I said we discussing feedback, the effect of feedback on treatment length, and maybe to use it to make decisions on treatment length. So in our country, usually there's also this issue of insurance companies maybe want to use it for those kind of decisions on how to give more sessions or to give treatment at all. And so we might want to discuss this issue also. I mean, in terms of, it's one side is to inspire or to motivate therapists to be part of it, but on the other side, it's also a tool which might be used by insurance companies, and that might be scaring to many people. So there might be also an additional point here. Yeah. How's this in other places? Maybe you can open the discussion a bit. Other people can't talk now, or?
They can,
Well,
but they have to raise their hand, so we know they want to talk.
Yeah.
But perhaps they're not having microphones, so in that case they have to type. I see that we have a comment here by
William again. Yeah, and he says, my experience is that therapists who at first are resistant to feedback actually grow to love it once they are trained properly. Just expecting therapists to work with feedback after only one training session is simply not enough.
Well, I would love to give several training sessions. I would have loved to do that, but I just didn't have the access to the therapist. So, I mean, I don't know how this is in the country that you work or the department that you work in. What we tried to do, obviously, is give several trainings to have repeated, sort of, do a repeat session and another repeat session. But, you know, and I actually did this. I think like I presented some in-between results and then used that to sort of get access to the therapist again and train them a little bit more. But the problem can be the management. If they don't give you access to the therapist and you know, provide the time to give this training, that is a problem. At least it was in my case. I don't know how this is elsewhere, but I suspect that it's similar. At least I've heard similar stories from Mike Lambert on that.
Well, I mean, that's what we try in our clinic. I mean, we basically, this is part of the clinical program, and each treatment is basically done with this concept, and students are already trained using it. And it's also a couple of workshops are connected to it. But we still discuss this issue, and to improve basically the use of the feedback for actual clinical work. So that's, I think that's also an area to how to implement those or to get this closer into clinical work, and also maybe the whole e-mental health debate, or to add interventional tools or clinical support tools is a way to improve the openness of therapists to use those kind of tools. So I think in the future it can be seen more as an outcome-oriented treatment or psychotherapy in comparison to more school or treatment approach-oriented psychotherapy.
Yes, yeah, I agree. And I also, just to come back to William's comment, is about, you know, therapists who are skeptical at first that can become really you know, enthusiastic about the feedback. what I found, but this may take a while sometimes, is that once therapists have had the experience of seeing something in the feedback, this can be in the risk items or this can be in the score, of something that they didn't see themselves, then they can see the sort of added effect of the feedback compared to their own clinical judgment. And in my experience, that is something that can be really helpful to have an experience like that, and that's usually sort of a turning point for people who are initially skeptic, and then they see, oh, you know, this patient is having suicidal thoughts, and we haven't discussed this for a while, and now I see that those thoughts are still there, and you know, that at least that's what kind of feedback I got from therapists about, you know, their opinion about the feedback.
William raised his hand, so I'll
and I have a
unmute.
microphone.
I'll unmute you, William. William?
Hello.
Hi, William.
Thank you very much. Thank you very much. Hello, everybody. Thank you very much, Kim, for an excellent presentation, and thank you, Wolfgang, as well. I completely agree with everything you're both saying, actually. I run an independent practice research network in the UK and have had 6 years' experience of recruiting therapists into working with feedback, and I absolutely agree that it has to be integrated into training, and it is only exactly that, what you've just said, Kim, is when practitioners really see the clinical value of working with feedback and come to observe directly in their clinical work the benefits of getting answers to questions they perhaps were surprised by, that it really hammers home to them the value of working with feedback. And in my experience, I supervise quite a lot of practitioners, and I actually won't supervise anyone who doesn't work with feedback, because as far as I'm concerned, they're working with their hands tied behind their back. And I find that once practitioners become used to working with feedback in that way, they would never be without it again, as I wouldn't myself working with clients. And I think that's probably the key to getting it integrated into the mainstream of practice over time. The other point is that I think what we need going forward is empirically supported therapists as opposed to empirically supported treatments. I think we're all sort of tired and jaded from the randomized clinical trials and the hierarchy of evidence and all of that. And of course that's all very important as well, but I think the opportunity to work with feedback brings forward a complementary form of research activity, really, where we can really learn a lot more about what helps our clients to make progress. So thank you very much for a really interesting presentation.
Thank you, William. Also, what maybe words to add to that is that patients actually like getting feedback a lot, and so they like it if they can sort of, you know, share looking at a graph with the therapist. And I think Wolfgang found in one of his studies that they value it really highly. They give really high rates, and that's also the experience that I found, although I didn't formally measure it. It is sort of the reactions that we got from the patients, that they really liked getting the feedback.
Okay. So Jim Payne asks, do people use feedback in supervision?
I think we already sort of covered it, at least William does with his group. And
we do.
You guys do that in your clinic, I think.
I like this statement from William about the certified therapists, but I mean, it's not an easy issue though. How do you want to do? How you actually want to do this? I mean, one way is basically certainly if they use, for example, feedback in the supervision process, especially in training, and that kind of could be certification during training or during the training. But on the other side, that's something we are struggling a little bit within our study, having just finished a large study with an insurance company here in several areas in Germany. So if you really certify therapists in their way, and though at some point it might be misused, the feedback, in the way that you find basically on the internet the information how to fill out the questionnaire to get more sessions and stuff like that. So, and or maybe the therapist tells the patients how to fill out those. So actually we certainly have also to study more closely how feedback is used and to control a little bit the circumstances in the way how it is used, so that we be a little bit careful that it not gets misused in some way.
Yeah, that is a little bit the situation that we currently have in the Netherlands, is that practitioners need to provide information on their outcomes to a benchmark, a national benchmark. And so this discussion is really going on, like, you know, do we not, you know, manipulate what kind of patients we measure, and that sort of thing. So once it is sort of being used for sort of the evaluation of the therapist, then you get into this sort of slippery fields where it's possible that it's misused. So I totally agree with you on that whole thing.
Okay. Are there any more questions or comments? If not, Kim, I think we would stop here.
Yes.
Yes.
This time also, I think.
Yeah, I think you shouldn't get a wrong impression of that new format of webinars. It wouldn't take always that long, I think. This is a very special one today. So I want to thank you very much, Kim, for sharing this interesting research with us. Also, I want to thank Wolfgang for your thoughtful comments and ideas. And I also want to thank all of you for listening and attending this webinar. And yeah, we'll hope to see you at the next webinar, which will take place on the 23rd of January and will be given by Dr. Bruce Wampelt. Yeah, so mark your calendars, iCals and Outlooks, the 23rd of January. Don't miss out on that one. So see you there, and goodbye.
And maybe worth telling that all webinars are recorded and are available on the SPR website.
Yeah.